Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. Today's podcast from Medical Protection is Driving Drugged, the Clinician's Guide to the Land Transport Drug Driving Amendment Act 2022. This act came into force on 11th of March this year and has implications for prescribers, and we're going to explore how this impacts you and how to minimise your risks. My name is Dr. Sam King. I'm a medico-legal consultant with Medical Protection. And joining me today to discuss this topic is Sean O'Sullivan, who's one of the partners at Watt & Carney, our panel law firm. Hi, Sean. Welcome to the podcast.
Thank you, Sam. It's a pleasure to be here.
And we've also got Dr. Tim Cookson and Dr. Lucy Gibbard, my colleagues at Medical Protection, who are also GPs. Welcome, guys.
Thanks, Sam.
Hi,
Good
Sam.
to be here.
Sean, may I start with you? Would you mind explaining to us what has actually changed under this amendment?
I think two important changes. The first is that the police will have the ability now to get drivers to undertake a blood test to see whether there's drugs in the blood. And the second is there's a listed schedule, Schedule 5, which contains 25 listed qualifying drugs. So those two things are now specific in the Act.
Okay, 25 listed qualifying drugs. Wow. And Tim, do you have any idea what's on that list?
Yes, I've had a look at the list, and there are 4 illicit drugs, and there are 21 prescription medicines on that list. And interestingly, the dosages, the blood levels are listed in there under 2 categories. One is tolerance, and the other, I think, is high or something along those lines. And Sean may be able to describe for us the relevance of those 2 numbers or categories.
Yes, Tim, it comes down to the penalties that might apply. Tolerance level is the lower level, and if it relates to penalties, so that if you were caught with a tolerance level, it's only an infringement notice, or over a tolerance level, it's only an infringement notice. If it's over a high risk concentration, then it might well be a criminal charge and a disqualification. Perhaps come on to penalties a bit later.
There's also another list, isn't there, under Section 2 of the Land Transport Act. And they don't talk about levels of the different medications. It's a very long list, mostly comprised of all the benzodiazepines I've ever heard of. And but it talks about the presence of those medications in your system. Is that treated any differently from the new Schedule 5 drugs?
No, I don't believe it is.
Great. So when it comes to the process that takes place, so let's just say a person is stopped by a police officer, what actually happens at that point?
Well, the police have to decide whether there's good cause to suspect that the driver is impaired by drugs, and good causes can be seen from perhaps erratic driving, and they appear to be under the influence of drugs. They can also ask the driver to go through a compulsory impairment test, which is a CIT, and a CIT is just a behavioural assessment. Includes consideration of the way they look, their eyes are functioning, their walk. They may have a few tests. The old walk along the line test might come back. That sort of thing is going to be used. And if they fail that test or they refuse it, then the police can require them to undertake a blood test under Section 73 of the Act. In my early days dealing with this, good cause is very widely defined. So it can be a very wide assessment in terms of it. It's not restricted in any way.
And I'm assuming that, let's just say you're involved in a car accident. Is it a mandatory test at that point?
Yes, and also an accident would provide good cause anyway, if you know what I mean. So yes, it would be always that you'd have a mandatory test after an accident.
Even if you weren't at fault?
Yes.
Interesting.
Can people say no to that blood test? If you're the driver and you say, no, I haven't taken any drugs, but I'm scared of needles, I don't want your blood test. What happens when drivers say no to the test?
Then they can be arrested and forced to have a blood test, as they can at the moment, because as long as the police have good cause to suspect, and I suppose I'm saying by its very nature an accident will provide good cause.
So there's no saying, there's no autonomy there for the the driver. That really you just got to comply.
You just have to comply.
And in terms of penalties, what are the possibilities for the patient?
Okay, so if they've got, we're going to come to a defence soon, but talking about the penalties per se, if a person has a tolerance level and is just over the tolerance level, then the penalties are a fine of up to $500 and an infringement fee of $250. But if they're found with a high risk concentration, and again the defence doesn't apply, then that's a criminal offence, and the maximum penalty I think is imprisonment for a term of not exceeding 3 months, a fine of not exceeding a maximum fine of $4,500, and disqualification for at least 6 months. So it's quite serious.
So you talked about a possible defence. Would you mind just telling us about that?
Yes, I will. The Act wants to strike a balance between allowing people to take drugs that they need and that are appropriately prescribed, but also sort of reducing the risk by them driving. So it's trying to strike that balance by giving, making it a defence, but giving the driver a defence to it. The defence arises if the driver can demonstrate that he or she took the medicine according to a current and valid prescription from a health practitioner, then that's the first step. And you also have to show that they have followed any instructions from a health practitioner and also the manufacturer of the medicine. So if they can show that they have a valid prescription for the medicine and they've followed the advice of the GP or the prescriber, then they have a defence to the offence.
So if I gave my patient a script for some lorazepam, and so I'd written the script and it was a valid script, and I'd forgotten to tell the patient that they shouldn't drive, and they were impaired and they were caught drug driving, even though the patient was impaired, they won't be at fault. They won't be found liable.
Yes, that's right. They will be able to show that they have followed your instructions.
So even though they're impaired, that's not the point.
No.
The point is that their doctor told them to take that medication.
Correct.
And so they've taken it, and even though they're impaired in driving, that's not a criminal offence if your doctor told you to take the meds.
No, because they will say, quite rightly, that my doctor gave me this medicine. I took it exactly the way he or she told me to take it.
So that's fine for the patient then.
Yes.
What about for the prescriber? Are there
I
any
thought
risks
you might
for
ask
the
me that question. Yes, at that stage, there's the ability for anyone to refer that GP to the HDC for not providing the appropriate advice. So that's where the vulnerability of the GP will arise. Not in respect of the offence directly, but in respect of possible consequences with HDC complaint or medical council complaint.
Yeah, because the medical council could think of this as a conduct or a competency thing.
A competence issue, probably, yes. And also in a coronial inquest, it could be really important if there was a death, and the consequence of that would be quite severe. So yeah, there are consequences for that.
So Sean, even if let's just say a doctor has prescribed recklessly, they've prescribed high doses and been very loose in terms of the instructions to the patient, hasn't warned them you shouldn't be driving, and someone dies. Are you saying that the doctor wouldn't be held criminally liable?
Correct. It would be a disciplinary process through the HDC or the medical council.
That's great. And with regards to, Tim, you're a clinician, and with regards to the concentrations which they have listed on Schedule 5, when we prescribe, do you have any idea of how much temazepam you would need to prescribe in order to reach that high concentration that they've listed in the schedule?
Nope, it's completely meaningless to me as a clinician, these numbers. And if you look at something like the New Zealand formulary or MedSafe data sheets, it doesn't actually list the likely therapeutic levels that you're going to get in your blood for the particular doses that are prescribed. So I out of interest, I thought, well, look, let's see if I can find what these might be. It's not as easy as you might think to find the therapeutic levels. So it did take a bit of digging, and I was intrigued by some of the results. So, for example, oxycodone is regarded as having a therapeutic level anywhere from 10 to 100 nanograms per mil. If you look at the numbers for tolerance and high-risk concentration, for oxycodone, 20 is the number for tolerance and 50 is the number for high risk. So you could have someone who's getting absolutely the right dose of oxycodone and they're going to be in that high-risk group. And so I think that carries significant risk for the doctor involved. It's the same for morphine. If you've got therapeutic levels that are likely to be sufficient to control significant pain, so you've got a cancer patient who's on quite a high dose of oral morphine, they're likely to be well above the high risk level. And it's the same for tramadol. You can be above the high risk level.
But that, in some ways, that doesn't matter so much as the impairment issue, don't you think, Tim? Because actually, if that has been prescribed by you or by a doctor or a clinician, then actually the patient has got a defence. So the patient's not going to be criminally liable. So then the real issue has got to be, is that prescription causing the patient to be impaired in their driving? Surely that's what the doctor's got to think about?
Yeah, but as I understand it, these lists have been produced and the numbers have been produced because that's where they regard the risk for driving to be. Impairment. Right. So even though, yes, you've been increasing the morphine steadily, they seem to be tolerant of it. It's a bit like alcohol. They may still be quite impaired, even though they're functioning reasonably well. So I think it does create an onus on the doctors to be warning our patients and more, and specifically recording what we warn our patients. And the other thing too is something like lorazepam. Of course, if someone's only taking it at night, but if we're not aware of the pharmacodynamics of it, when does a peak level occur? How long is it going to stay at that peak dose? We've got to be even more precise in our advice about how to take those medications, when to drive, when not to drive.
Yeah, I think that's the important point, is that this creates another area where you're going to come into a lot of scrutiny for the advice you provided and the notes that you've taken of that advice. So, I mean, that's always an important thing anyway. I'm just saying it opens up a door to another line of scrutiny that you'll be under, and sometimes in very difficult situations like a death on a road or other situations.
You can imagine this would be a situation where there would be conflict between the patient and the doctor, with the doctor saying, I told the patient not to drive, and the patient said, well, I don't remember that. That you can just see that happening frequently, can't you?
Absolutely, and that's why the notes are going to be so crucial.
And because this is, we've always known that we needed to advise our patients, but often I think the bit that was missing was documenting that we've done that. This just increases the onus, really, doesn't it? The importance of documenting and making it really clear what you've advised, not just that you've advised, but perhaps being more specific than that.
Absolutely, because every patient in this situation will want to draw the GP in to get that open the doorway to that justification or that defence. And so what has happened between the GP and the patient, it will be absolutely crucial.
And the advice will be different because, coming back to lorazepam, you might be able to safely advise your patient, if you take one of these, then don't drive for 10 hours after you've taken it, or whatever the number might be. But for someone who's on regular morphine and they're keeping their blood levels constant, then actually that impairment is going to be all the time. They're not going to be safe to drive.
Until such time as the sedation wears off. Because we have a lot of patients who are taking regular doses of morphine who we are allowing to drive because actually they're stable on it and they're no longer sedated with it.
But if they're on a reasonable dose, they'll fall into this high-risk concentration. And so if they're picked up by their driving, and their driving is perceived to be impaired.
But the patient will be all right because they'll say, I'm taking it at the instructions of my doctor, and the doctor will be all right because they can say, but the patient's been on that stable dose for the last 3 months. I think every reasonable clinician in this situation would agree with me that after being on that dose for 3 months and my observations of the patient not being impaired are enough to make it a reasonable thing for me to allow them to drive.
That's correct. There'll be situations where they're over the toxic level, and they're taking, you're just telling me you're taking the drugs and consistent with the advice provided, and the advice provided is reasonable advice. And so that's going to be fine.
Okay, so what you then have to do is you're going to have to record when you see them again. I am not observing any signs of impairment from the dose of morphine that is being prescribed.
Yeah.
Because without that evidence beforehand, if there is a crash, then the prosecution lawyer is going to argue something quite different.
Tim, you're terrifying me now because clearly we don't always do that. And I'm just thinking of all the patients that we do have, and I'm particularly thinking about palliative patients who are on quite long-term regular doses. I don't think I've ever written down an observation about impairment, but I've definitely said, once you're stable on this medication and you're not sedated anymore and, everything's all right, well, then you are allowed to drive as long as there's no impairment. But I don't actually necessarily then go back and ask them if they're impaired.
So
I think it's about the warning of the patient in the same way that we warn about any side effect or potential side effect. We need to warn them about the possibility of sedation. I think part of the difficulty comes when you're relying on a patient it's about a self-judgment. Am I impaired? No, I think I'm fine. But they may not be. In the same way that we think that after a few glasses of wine, we're going to be fine, but in reality, we're not. I wonder if that's the same case with, medication as well.
One of the papers that I read had an interesting story. Now, it is from America, so we do need to treat it with a little bit of a grain of salt, but the principles might apply. And this was a psychiatrist who was prescribing one of these medications that's on the list. And he had actually not only recorded that he couldn't observe any impairment from the dose that this patient was taking, but had taken some blood levels as well, and so could show that at this particular blood level there was no visible signs of impairment, because then that patient became involved in a car crash, had his blood levels measured, they were over whatever the limits were in that jurisdiction, and he was charged and sued on that basis. And it was only the defence was, well, actually, I know that I wasn't impaired because my doctor took these blood levels and we knew that I didn't have impairment at those particular blood levels. Now, I don't think we've got quite that far in New Zealand, but I'm sorry to scare you again.
I'm
Lucy,
terrified. I'm terrified. But look, one of the things that we were thinking about was about how we're going to record this then, because actually this has kind of brought it to the front. That obligation has always been there to warn people about sedation or impairment when you're using these medications. So then we've got to think about how are we going to help ourselves here and actually make that easier to record, and what do we need to actually record? Sam?
I mean, as you know, particularly in primary care, our notes tend to be quite contracted, if you like. And so often we would say warned sedation. But I think perhaps we need to be a little more detailed than that in terms of I've given specific instructions about taking it this many times. We've warned that if you take more than this, that, and you get an increase in impairment, that, and you have an accident, etc., etc. So it's full informed consent by the patient as to what they do with the medication from that point. So I think we probably need to be more comprehensive in our documentation.
Do you think we all need a list of these 25 drugs on our wall? Or 21 are prescribable, aren't they? The 4 are not. Those 21 drugs, should we all have a list so every time we prescribe one of those 21 drugs, we specifically say to the patient, this is on Schedule 5? Should we be doing that?
Well, isn't this a case where the practice management systems providers could actually do something useful with technology, and they could get this list, and that every time you try and prescribe one of those, there'll be a pop-up warning that says record advice to patient.
Can I suggest too that maybe the safety netting advice of stop driving if you suffer any of these consequences. You can set them out, drowsiness, or put that in your notes as well, or explain that to them, because that I'm also, I think, is an effective way of covering off those bases.
Maybe we need to have an information sheet that we routinely go through with our patients and give it to them, and then we can say, discussed, potential sedation, given the information sheet, and talk through it, and that way
Schedule 5 sheet given to patients.
Yeah.
What do you think about a hotkey just to remind us what we are talking about? Do you think that would be a reasonable thing? I know the HDC doesn't like hotkeys.
Yes, and they get misused so much that you can sort of understand why the HDC doesn't like them. But a template reminder would be fine, so long as you have to actually physically fill in the answer. So it could be a template reminder says discussed possible impacts on driving with patient, and then you have to put yes and then annotate if there's anything particular that you advised. No driving for 10 hours after lorazepam, or whatever it might be.
I do think actually having an information sheet, a Schedule 5 information sheet that you actually had in resources in your practice that you handed out, and then you'd only have to annotate that this information was given to information sheet was given to the patient. That might be a useful thing.
Yeah.
From a legal and non-clinical perspective and risk analysis, yes, I think it'd be a great idea.
Just one last thing. I was thinking, for some patients, they're on these medications long term. And right at the beginning, when you initiate the medication, you will probably have had a good talk to them about the potential sedation, etc., etc. But over years, we tend to forget about that. Do you think, or how often do you think we need to have that conversation about possible sedation with medication?
It depends, because I think if they're using it regularly, a lot of medications become less sedative if you're using it regularly. But if it's a medication that they're using intermittently, like if they're taking codeine for a migraine or something like that, so they're using it very intermittently, you'd have thought that actually there is some obligation to actually keep saying something. I don't know, Sam. What do you? I'm not sure.
Well, even with the long-term ones, I'm just trying to think. What will the HDC say? And the HDC will say, well, what would a reasonable patient expect to have as information from doctor? And it may well be that the HDC would say, well, actually, we don't expect reasonable patients to be able to remember what they were told 3 years ago relating to this medication. Then the problem is, well, as you say, Sam, how often would a reminder need to be done?
I wonder whether with a dose change, we should always go over the possible risks of sedation again. And I wonder pharmacists generally are very good about warning patients, and they often put that on the
label.
Box, on the label. And so maybe if we make sure that we add it to the patient label, so that, and then the pharmacist can reiterate that. I wonder whether that's
so there's a constant reminder. Yes. So every time they get a prescription, that's actually a reminder. Yep.
The problem is that, oh gosh, it's remembering everything, isn't it? That's my problem, is that, oh my goodness, how am I going to remember those 21 drugs? And in reality, it's not just those 21 drugs, is it? Actually, it's any drug that may cause sedation we should be doing it with. That's,
But these are certainly the ones that have been identified as being the most likely to be hazardous with driving. Yep.
Right. So that's how they got onto that Schedule 5, because they were actually causing problems.
Yep.
Oh dear, better go back to the practice and sort myself out.
So if we can just sum this up, how can clinicians keep themselves safe in this situation? Just as a summary.
I think provide the appropriate advice at a time, and take very good notes, and perhaps that safety netting advice and also if you stop driving, you've experienced any of the following. And I think, Lucy, your idea of a template in that situation is probably very valid.
Yeah, good notes. That's the thing. Have the conversation and then record it.
It always comes back to good notes.
It does come back to good notes. And also giving the patient written information, because I think, that is an extra layer of safety. But actually, when you give them the information, that you actually record that you've given them the information as well.
Yep, and just providing written information alone is not informed consent, of course, as we know. So it's the discussion as well that's critical. So you've got to say discussed possible impairment and provided pamphlet or leaflet.
So essentially we need the 20-minute appointment, not the 15-minute appointment for this one
Might
matter.
be half an hour, Sam.
So thank you for listening to this podcast. I hope it's been helpful. We look forward to catching up with you in our next podcast. If you like the Medical Protection podcasts, please subscribe and leave a review. If you would like a podcast on a specific topic, please email nzpodcasts@medicalprotection.org. I'd like to thank Sean and Tim and Lucy for joining me today. Thanks, guys.
My pleasure.
Cheers, Sam.
And thanks to our listeners. We'll catch you again soon.